Hello, friends. Today we'll see the clinical features of Guillain-Barré syndrome. So let's start. It is an acute disorder. Guillain-Barré syndrome is an acute disorder, and it usually progresses for few days and rarely up to 1 month. It can progress, right? It is predominant motor neuropathy. Predominant motor. You have to write motor neuropathy. There is nothing sensory in this, and sensory findings are minimum, right? And consists of if someone asks you what are the sensory findings and how it can be sensory, so you just have to answer that it consists of distal paresthesia. There may be some kind of weakness paresthesias, right? And there may be mildly disturbed joint position sense, so disturbance may be there in your joint position sense. Next, so this is clear, right? So motor paralysis is the most striking feature. That's what you have to understand. Motor paralysis is more striking, and which kind of motor paralysis is there? So please remember that it is symmetrical motor paralysis. Okay, so symmetrical means it involves proximal muscles more than distal, right? So it begins in the legs. So first of all, it will begin in the legs, and over several days it will progress, and it will involve your arms, after that your face, and then your eyes. So this is called as ascending paralysis. So in Guillain-Barré you will see ascending paralysis, right? Reflexes are absent. There will be no reflexes, and 50% patients will show bifacial weakness. Great. So some may show bulbar muscle weakness. Some show respiratory paralysis. Autonomic disturbances also occurs in a few, resulting in sudden fluctuation in your BP and heart rate. So BP and heart rate should be monitored in this syndrome. And bladder involvement is rare, so I'll not mention it. And clear sensory level and marked bladder involvement are against the diagnosis of Guillain-Barré syndrome. Similarly, the extensor plantar response is extremely rare. So in the Guillain-Barré syndrome, one thing which we have to understand is what is Miller-Fisher syndrome. Miller-Fisher syndrome. It is a variant of Guillain-Barré syndrome. So whenever they are asking you a question about Guillain-Barré syndrome, you have to write this name. This is a variant of Guillain-Barré syndrome, Miller-Fisher syndrome, and it is characterized by areflexia, ataxia, and ophthalmoplegia. Okay, AAO, right? So often it may be preceded by Campylobacter jejuni infection, And the other variants are again acute motor axonal neuropathy, which progresses more rapidly and has an earlier peak than demyelinating GBS. Tendon reflexes are relatively preserved or even exaggerated. Autonomic dysfunction is rare. Acute and motor sensory axonal neuropathy may be there. So, what we have to understand is how to investigate this kind of syndrome. So, first of all, we'll see the CSF. We'll investigate the CSF findings. Okay, and CSF becomes abnormal after 1 week. So that we have to mention. After the 1 weeks of illness, the CSF will become abnormal and shows raised proteins more than 45 milligram per deciliter. The sugar will be normal and the cell count will be generally less than 10 per millimeter cube. Rarely count may go up to 50 cells per mm cube, but never above that. So this is known as albuminocytological dissociation. Okay, that means that the proteins are raised more than 45 milligram per deciliter, and the CSF will be abnormal after 1 week of illness, and there will be normal sugar and the cell count will be generally less than 10 per mm cube. Okay, so this is known as albuminocytological disorder. So nerve conduction velocity studies also can be done. These studies will show the velocities, the demyelination pattern. That's why you should do nerve conduction velocity. Okay, after that, acute intermittent porphyria. And post-diphtheric neuritis and drug-induced polyneuropathies will need to be ruled out. So that is what also comes under your investigation. So lastly, I would like to touch about the topic of treatment. How will you treat the patient of Guillain-Barré syndrome? So first of all, the immediate management of the patient with GB syndrome consists of maintenance of your airway, breathing and circulation, and ventilate if the patient develops respiratory failure. You have to monitor the pulse, undoubtedly. You have to monitor the BP and the cardiac activity. How will you monitor it? By using a cardiac monitor. As these patients have autonomic instability, so and the steroids are of no value in this syndrome. Ultimately, you have to do plasmapheresis. If it doesn't stop, plasmapheresis will be needed, and or you can give an IV IgG, IV immunoglobulins, and how much is 0.4 gram per kg per day is the amount for 5 days, right? Or you can give for 2 gram per day for 2 days. So these can accelerate the recovery. So thank you for watching the video. If you like the video, please like it and subscribe to my channel. Thank you.